Get started. So let's start with EKG rapid diagnoses. So I'm not here to kind of teach how to read EKG. It's more just pattern recognition at this stage. So can someone tell me what they kind of see here, what they think this is? So, are you seeing P waves? No, right? Is it narrow or wide complex?
Wide.
It's more wide, right? So do you think it's more atrial or ventricular in origin?
Ventricular.
Yep, ventricular. What is it? VFib. Nice, VFib. Okay. Treatment of VFib, just very broadly.
Gravity version.
Yeah, this is a shockable rhythm. So you can also have epi-CPR. So what's the pathophys of VFib? Like, what will it look like under an echo if you were to look at VFib? What is essentially the physiology? Exactly, fibrillation of the ventricles. So the ventricles are essentially fluttering, having very, very weak contractions, and essentially not having any blood delivery or perfusion to your extremity. Okay, another ventricular origin, right? Is this narrow wide complex? Wide complex, again, great. You see any P waves? No P waves. So this is what? VTAC, you got it. So there are a couple of different types of VTAC. This just happens to be monomorphic VTAC, meaning each wave looks the same. But what is treatment of VTAC?
Amio.
Isn't it like
Amiodarone for cancer?
Yep, you can do shock, and then you can have amiodarone as well. Can treat VTAC. Synchronized shock if they're unstable. And the medical treatment, like we said, amiodarone. Very good. What are some side effects of amiodarone? Side effects of amiodarone. So I heard one, hypo or hyperthyroidism, or both. Both. You got it. What's the main component by molecular weight of amiodarone? Iodine. You got it. Okay, and then it can also cause like a bluish gray pigmentation. It can cause liver issues, and then it can cause what in the lung?
Why just have carnots?
Lung fibrosis, I believe. Right? Okay. All right. Next panel, what do we see here? Do you see P waves? No. And is it narrow or wide complex? Wide complex, you got it. So it's ventricular in origin, right? And no atrial component. So what are you noticing about the QRS complex itself, about the R wave? It looks like sinusoidal, right? What is that indicative of? Torsades, right? So that's the twisting of points around like a central string. So that's torsades, they point. Pathophys of torsades. What's the kind of general pathophys of things that induce torsades? Things up along the QT interval. You got it. So that can include medications generally, but also some genetic conditions. So this is more of a board's artifact. But if they have congenital deafness and long QTs, anyone know this? Durable Lange syndrome. This is a board's artifact. You probably won't need to know this. So this is an example of what QTC here is greater than 480 milliseconds. Don't overthink it.
QT prolongation.
Yeah, it's long QT syndrome. So I just have this slide here so you know the different kind of etiologies of long QT syndrome. But mostly look for medications, electrolyte abnormalities, especially on exam purposes. But you got some more EKGs. What are we looking at here? Do you guys see P waves? Yeah, maybe, right? Hard to see. Maybe they're buried, right? But probably leading no. Is narrow or wide complex? Narrow complex. And then tachycardia, regular rate. What do you guys think? Tachycardic, right? So narrow, complex tachycardia. And is it regular or irregular? Regular, right? So what do we think this is? PSVT, you got it. Or SVT, right? What does that stand for? Supraventricular tachycardia. What significance of this type of arrhythmia being supraventricular? What does that tell you?
atrial?
It means it originates either in the atrium or in the AV node, right? So that means that it's not of ventricular origin, which explains the narrow complex. Exactly. What's the treatment generally? There are non-pharmacologic and pharmacologic treatment.
Synchronized cardioversion, Denzi.
Yep. So you can do shocking, and then there's another non-medication, non-pharmacologic treatment. So I heard that Valsalva. maneuver that's the least invasive, so you always want to start with that. And then the medical treatment, adenosine, you got it. Does anyone know how adenosine works?
It's like a blocking.
You got it. It is, you actually basically reset the heart. So when you guys give as a resident, it will actually cause flatlining and you'll get really nervous, and then the heartbeat will restart. So that's it. Essentially is such a powerful AV nodal blocker that you're restarting the heart. So adenosine, you got it. Start with vagal maneuvers, and then you can also do shocking.
Definitive treatment would be an ablation too.
Right. Definitive treatment's an ablation. Absolutely. And then the pathophys is a nodal reentry, right? So you have your AV NRT, and then the other one is AVRT, right? Yeah. Okay, what are we seeing here? What is this EKG showing you? So you see a P wave? Yep, you see a P wave. Narrow or wide complex? Kind of hard to say, right? Like, yeah, kind of wide complex. What is the notable positive arrow sign you see here?
A delta wave.
Delta wave. So what is that indicative of? Delta wave?
A Wolf Parkinson.
You got it. Wolf Parkinson's White. What's the treatment of Wolf Parkinson White? Medication-wise, procainamide. Absolutely. Why do you want to avoid? So if a person with Wolf Parkinson White has like AFib or something like that, why do you want to avoid nodal blockers? Like, let's just say they have a AFib. You're like, oh, this is easy. We'll just start. What do you normally start for AFib? For rate control with rapid ventricular response, AFib, RVR. What do you
Like
use
a
to treat that?
Like a beta blocker.
Yeah, you got it. Beta blocker, metoprolol, or diltiazem, right? What's diltiazem? Calcium channel blocker. You got it. So why would we want to avoid that Wolf Parkinson White?
Push the signal through the accessory pathway.
Yeah, you got it. So you'll shunt the signal through the accessory pathway of what? Pathway of Kent. You got it. All right, pathophys, accessory pathway of Kent for Wolf Parkinson White. So that's why you have a discrepancy in the electrical signal that gives you your delta wave. Okay. Next, we have a very simple bread and butter. You should be able to get this one like instantly. You will be tested on this many times in your medical career. So tell me what you're seeing here. You're seeing P waves? No P waves. Narrow, broad complex. Narrow complex. Regular, irregular. Irregular. What do we think this is? AFib. If you were to calculate the ventricular rate, how would you do that? Yeah, I would count the whole strip, right? You don't want to just go from R wave to R wave here because it's irregular. Nice. All right, treatment. So we'll walk through AFib treatment. Just broadly tell me right away, AFib, RVR, what do we use in treatment? We just talked about this.
Rate control.
Rate control, you got it. And then for chronic treatment, you can also consider rhythm control. There have been some newer studies. I'm not sure what you're taught in class, but the past consensus was rate control was equivalent to rhythm control, but some studies now recommend a little more rhythm control because it's sometimes better for symptomatic management. But just go with what they taught you in class for exam purposes. And then what do you want for long term if their risk is high enough? What else do you include in their treatment? Anticoagulation. What do we use to determine if they are a good candidate for anticoagulation chronically? Yeah, the Chad's too vast score. You got it. So what's your anticoagulant of choice that we talked about last session? Yeah, right. So what do we used to use? Good old warfarin, right? Rat poison. And now we switch over to DOACs, the direct oral anticoagulant. Absolutely. And then when starting anticoagulation, I don't know how much to cover this in class, but you don't always want to just start it right away. If they've had AFib for a while, then you are worried about what? Why are you anticoagulating these patients? Right, there's stroke. Why? Because remember Virchow's triad, anytime you have stasis, you can get thrombus buildup, right? Where does a thrombus tend to accumulate in patients with AFib? Yeah, the left atrial appendage, exactly. So if you want to start a patient on AFib and they've had AFib for a while, and you want to start them with anticoagulation right away, you actually have to do imaging with the TEE to make sure they don't have clotting in their left atrial appendage. Okay? And then pathophys of AFib. This is a little bit more nitty gritty into the weeds, but it's a pulmonary vein automaticity focus. So treatment for recalcitrant AFib is actually ablation around the pulmonary vein annulus. Yeah. Okay, these are some triggers of AFib. So what is mechanistically, think to your anatomy, what types of things trigger AFib? So what is your main anatomical trigger for AFib? Right. Whenever I think about disease, I think about anatomy, physiology, then the pathophys, right? You combine the anatomy, physiology to find the cause and the treatment, right? So what anatomically can contribute to AFib? So think about what valvular pathology is associated with AFib. Mitral stenosis and regurg, right? Why is that?
Because then you're going to get left atrial enlargement.
Exactly. That's what I was looking for. Left atrial dilation. So anytime you have left atrial dilation, you'll be more at prone for AFib. So a lot of these things that I've listed here, heart failure, left atrial dilation, valvular disease, especially mitral disease, COPD can cause like right heart failure. Hyperthyroidism just causes, essentially a catecholamine excess. So you have an accelerated heart rate. And stress and alcohol. Alcohol classically was called the holiday heart, right? Okay. Is this narrow broad complex? Narrow, right? Yeah, I'd say narrow complex. So narrow complex, what do we think the diagnosis is here? Morphology is what's going to give this one away. And it's next to the AFib slide. So yeah, atrial flutter. Yeah. It's not cheating, right? You're using your context clues. A-flutter, broadly, what is the treatment for A-flutter? About the same as AFib. Yeah, exactly. So often harder to treat than AFib with ablation. So often it's ablation with the tricuspid annulus. And it's a tricuspid annulus re-entrant circuit. But you also want to do your rate versus rhythm control. But it's a little harder to have rate control with atrial flutter. But I stand corrected. I think actually the ablation works a little bit better for atrial flutter compared to AFib, because in AFib you want to think about that underlying conduction pathology with left atrial dilation. Question?
Are A-flutter patients also at increased stroke risk?
Yes. Yeah. A-flutter patient also increased stroke risk, right? It's very similar to AFib mechanistically, so you still have increased risk of clot in the left atrial appendage. So you'll treat them as well with your anticoagulation. You got it. Okay. Next question. What are we seeing here on V1 and V6?
Left bundle.
Yeah. What makes you say left bundle branch block? What do you see here?
It's a wide QRS. Personally, I mostly just use V1, but it's a wide QRS, and then following the ST segment, the first inflection in the QRS is negative.
Yeah, you got it. So you see the wide complex QRS, right? So that instantly tells you that this has some kind of ventricular origin. And then the downward R in V1, the RS that you see in V1, and then your downward inflection in V6. And it's just this is like the Mickey Mouse ears is what they call it, right? Or the rabbit ears in V6. Okay, so that leaves you with the other one here. So here in V1, you have that like bimodal, or yeah, your RR, your little r, big R, and then your big R in V6. So what is this?
Right.
Yeah, right bundle branch block. Does that make sense to everyone? Okay, great. This is a very poor quality image, but hopefully you're able to get it. So what are we seeing here that immediately jumps out at you? What interval is it lengthened?
The PR.
PR interval, right? So what is this? You got it. First degree AV block. Yep, just look at the PR interval. Not gonna lie, this is probably a better quality image than you'll see on most exams. Yeah, so this is actually pretty accurate. So really, you'll just have to use context clues, and you can see the PR interval is prolonged here, right? So treatment, first degree AV block. Yeah, kind of trick question. It's usually observation unless it's highly symptomatic. And remember, this is a intra or infranodal block. Intranodal block. You got it. Okay, what do we have here? So we have. Tell me about the PR interval. It's getting lengthening, right? So PR interval lengthening, and then you have a dropped QRS. So what is this?
Type 1, type 2.
You got it. This is a AV. So this is a second degree AV block, Mobitz type 1. Okay, that's your prolonged PR interval, then a drop beat. Okay, treatment of this type of heart block, if asymptomatic. Same thing, right? Benign observation. And why is that? What's the location of this heart block? You got it, intranodal. You guys see the pattern. Okay, what are we seeing here? Tell me about the PR interval here. Is it lengthening or the same? All right, great. PR interval, same here. And then you have a drop beat. What is this? You got it. Second degree AV block, Mobitz type 2. What's treatment of this type of AV nodal block? You got it. So this requires pacing. And is it a intra or infra nodal block? You got it. It's a infra or below the AV node block. So that's why we need to pace these patients. And then tell me about this EKG here. This actually is, I find this one to be the most difficult. Yeah. But what are we seeing? So tell me about the Q, like the RR intervals. Are the RR intervals changing? Is it a drop beat? RR intervals are the same, right? So, but it seems like the RR intervals differ from the P wave intervals, right? So what is this? Third degree AV block. Treatment? Pacing again, right? Why is that? Infranodal block. Yeah, exactly. So I remember when I learned this, it first took me like a week to figure all these EKGs out, but really you just look for the pattern recognition, right? So first degree, look for a prolonged PR interval. Second degree, Mobitz type 1, look for the prolonging PR interval and then a drop beat. Second degree AV type 2, look for the consistent PR interval. Third degree AV block, look for the RR intervals to be the same and the P intervals to be the same. And then they overlap and look funky, basically. Okay? All right. So tell me about stroke volume now. So we're doing physiology. I know this is everyone's most favorite part of the unit. So tell me first, what factors affect stroke volume?
Load.
Yep. Preload. And what else? What other load? Afterload. You got it. Okay, that's what I was looking for. Stroke volume increases with increase or decreases in contractility with higher contractility or lower. Higher contractility, right? Higher preload or higher lower preload, stroke volume will increase. Right. Higher preload, you'll get higher stroke volume. Then what about afterload? Lower. You got it. So with a higher afterload, you get a lower stroke volume. What is another kind of name for afterload? Like your systemic vascular resistance, you might see it called. Okay, why does heart failure reduce stroke volume? What are like the two types of heart failure that would reduce the stroke volume?
Increased contractility.
You got it. So one's decreased contractility. What is that type of heart failure called? HFrEF, right? So heart failure, reduced ejection fraction, or systolic heart failure. And then your other type of heart failure, then what's that? Diastolic heart failure, right? And that is impaired preload. Exactly. You have an impairment in diastole, right? So we have a bunch of names for everything in cardiology. But really, in cardiology, this is the one block we really want to think back to fundamental physiology. Okay? So this is what we just talked about, right? All right. So these are just some equations that you really should know. Really, a lot of them are pretty intuitive. So if you want to calculate stroke volume, I just remember that they love to test these equations. Like they'll give you the numbers for each of these, and you need to figure out what they each mean. But really, from your intuition alone, you should be able to derive these, right? You don't have to be Isaac Newton and derive calculus to figure these out. Like stroke volume will be your end diastolic volume, which is how much you have. That's the maximum filling you'll have, right? Minus the end systolic volume, because that'll be right after your ejection. So you calculate how much was ejected, and then to find the fraction that was ejected, it's just like any other fraction, right? It's the stroke volume divided by how much was in the heart initially. Cardiac output, you can also use fixed principle, and the cardiac output itself will be the stroke volume times the heart rate. And then, of course, your MAP is really how you'll to know that's your cardiac output times the total peripheral resistance. You can also use 2/3 diastolic blood pressure plus 1/3 systolic blood pressure, but I'm actually not sure which of these is more commonly tested. But I know these are all technically fair game. for your exams moving forward. So you can usually figure these out with intuition, but for anyone that likes to memorize formulas, here they are. Okay, so here's the Starling curve, like description. So this is the Starling curve, right? And you should all know this by, have some understanding of this, right? On the y-axis, you have your stroke volume. On the x-axis, you have your ventricular preload. Is this new? Is this known? This was taught. Okay, good. So let's just think about things that increase the Starling curve. Okay, so with increased preload, do you typically get increased or decreased contraction or stroke volume? It'll increase, right? Because you have wall stretch, which up to a certain point will result in a higher stroke volume. Okay. And then your contractility is the curve itself can be shifted up or down depending on your additional factors, right? So like catecholamines or digoxin can actually shift your contractility, which will shift the whole curve upwards. Whereas things that impair the contractility, like beta blockers, hypoxia, heart failure, will actually shift the curve down. Okay. So clinically, the reason you know this is just when they test this, they'll ask in heart failure, you'll see that your stroke volume is decreasing despite increased preload because your contractility is decreased. When you give inotropes, so what are some examples of inotropes? There's one big one. Digoxin is a big one, and then milrinone. So those will actually improve the stroke volume by shifting the entire curve upwards. Your diuretics will decrease your preload, so that will shift you more horizontally on the curve. And then, yeah, that's about it. All right, so we'll do another example of the Starling curve. This is very fun. So tell me, what does the intersection of the red and blue lines mean? And it's not Darth Vader fighting against Luke Skywalker. What is the significance of the intersection? What does that point tell you? Anyone know? Do they go over this?
Your cardiac output.
It's your cardiac output. You got it. Do you guys go over this?
Yeah.
Okay. Yeah.
Like 8 years ago. Sorry.
Yeah, like
Okay.
4 weeks ago. So.
Oh, okay. Well, this
But
is
this is good. This is good.
this is important to
That's
know
what we need.
because
If
it
you get
is
quiet, that's what we need.
it's fundamental to the understanding of like a lot of the pathology. So when you think about cardiology, you really should. I mean, I still think about this graph sometimes, just because sometimes there are a lot of different factors at play. So you need to kind of sift through them each to figure out what will happen. So what will happen to the curves if inotropy increases? So tell me a color and up or down.
Red.
Red up. You got it. So cardiac function will increase because you have higher contractility, right? This was the original curve that I just showed. That's what red was, right? Red is this curve, right? Starling curve. Okay. What if inotropy decreases? Red down. Very good. All right. If venous tone increases, what will happen to preload? You got it. So when we have venoconstriction, constriction of the veins, you have more preload because you have more venous return to the right atrium, right? So what will happen if venous tone increases? Blue up and to the right. You got it. And if venous tone decreases?
Down.
Blue down and to the left. You got it. And then if total peripheral resistance decreases, what will happen to cardiac output? So cardiac output should go up, right? So what will happen to the curves? They both go up. Nailed it, right? So you can always deduce your answer through a few different ways. And if total peripheral resistance increases, they're both down. You got it. Good work. Okay, any questions about that? Pretty intuitive, right? Once you think about it like that. It's actually pretty easy graph to draw. It's 2 lines. All right, you ready for the cases now? Okay, this is a fun part. That was all kind of boring filler stuff. That was all set up. Okay, a 55-year-old gentleman with a history of obesity, family history of stroke presents for routine exam. Blood pressure is elevated on 2 visits. No secondary causes found. What is it? How would you treat it when we start generally? Don't overthink. It's just hypertension. Yeah. So we treat with. So if the blood pressure cutoff is 130/80 on 2 occasions, then you treat. What's like your usual first line of choice?
Lifestyle.
Yep, lifestyle or thiazide. If their blood pressure is reasonable, like usually within like 140 SBP. So what are your medication agents? Yep, ACE, ARBs are usually your first line because they're protective against heart remodeling, right? And proteinuria or calcium channel blocker. What is a side effect of calcium channel blocker? The main one, most common side effect. What's that?
Lower extremity edema.
You got peripheral edema. About 10% of patients experience lower extremity edema. And then what's a side effect of ACE and ARB inhibitors?
Cough.
Yep, you can get a dry cough, but you can also get angioedema, which is life-threatening due to increase of bradykinin. And you can also have an increase in creatinine, which is expected. And you'll learn about that in the renal unit. Okay, let's see. This is a patient with poorly controlled hypertension presenting with a very high blood pressure of 210/125. Now with severe headache and blurry vision. On fundoscopy, you see papilledema, no chest pain or dyspnea though. Yeah, you got hypertensive. This would be an emergency because there's end organ damage. So essentially, you get such high blood pressure that you get some endothelial injury. So you need to have a gradual reduction in blood pressure over the next 1 to 2 days. Usually, you use your IV antihypertensives. So that's your nicardipine or labetalol. All right. So these are, I think, a little more fair game for you guys. So, oh, and just to clarify in the chat, just ACE inhibitors cause the angioedema component because of the elevation of bradykinin. Okay. All right. Thanks for clarifying. So, 68-year-old gentleman with a long history of hypertension, smoking history, has chest fullness and hoarseness. Chest X-ray showed widened mediastinum. CT angio shows ascending aortic dilation. What's kind of the treatment and risk factors for this? Yeah, you got it. So the main ones for aortic dilation are hypertension, but smoking can also contribute. And you can also have like weird causes, so Marfan's or aortitis from syphilis. So findings, you can have hoarseness due to compression of the recurrent laryngeal nerve or dysphagia, and treatment is with beta blockers and then surgical care greater than 5.5 centimeters. Okay, and the reason for that I bring this up is just because the complication is aortic dissection, and it's sometimes helpful to differentiate this from abdominal aneurysm. Okay, next case, a 70-year-old gentleman with high blood pressure and a 40-pack-year smoking history presents with a routine exam. A pulsatile non-tender abdominal mass is palpated below the umbilicus. What is the most likely diagnosis here? Don't overthink it, right? It's part of your physical exams. And what is the general screening and treatment and risk factors?
Aortic aneurysm.
Yeah, aortic aneurysm. You got it. So this is due to weakening of the aortic wall, generally in males greater than 65. So typically we actually have routine ultrasound for screening, repair greater than 5.5 centimeters. So next, a 58-year-old gentleman with uncontrolled high blood pressure presents with sudden severe tearing chest pain radiating to the back. Blood pressure is unequal between the arms, but the EKG is normal. What is the finding here? What's your next step in determining the treatment? What's the diagnosis? Yep, aortic dissection. You got it. And what kind of determines the treatment types? What are the types of aortic dissection?
A and B.
Type A and type B.
And if he's got different blood pressure in his arms, it's probably occurred somewhere in the ascending aorta before like where the three things come off.
Nice, right. So given the differential in the blood pressure, it's probably prior to the aortic arch. So it's most likely type A or B.
A.
Probably type A, right? Stand for type A, aortic dissection. And then what EKG finding can you see with aortic dissection? This is a hard one. You can see electrical alternans. Why? Sometimes you get a the most common finding is sinus tachycardia, which for many reasons, right? Pain being the big one, but you can develop a pericardial effusion at the same time you have an aortic dissection. Okay, so treatment, you need to determine if it's type A or type B. Imaging is gold standard is CT angio. Does anyone know the second line imaging if they're unstable? TEE, so transesophageal echo. And then treatment for type B is type B. What are we going to use? Starts with a B. Beta blockers. You got it. So stand for type B, beta blocker. Type A is surgery. All right. So there's our type A versus type B. All right. Another case. Oh, these cases are all numbered incorrectly because we're splicing a bunch of stuff. So ignore that. All right, 58-year-old gentleman, history of, whenever you see these like risk factors lumped together, think of them as vascular risk factors, okay? So it's like your holy trinity. It's like your mirepoix of vascular risk factors. Diabetes, hypertension, hyperlipidemia, and PAD has crushing chest pain, raining to the left arm, also knows shortness of breath, sweating, nausea. EKG shows S segment elevation of V1, V4. Diagnosis should be pretty simple here, right? What is this? MI, what type of MI? STEMI, right? ST segment elevation. So what is the specific type of MI? What vessel? What kind of location?
He's having a widowmaker.
All right, do we have a unified guess? I heard LAD, anterior MI, you got it. So first steps in treatment of MI. What's the old acronym that we like technically don't teach, but I still like to like go over? Mona bash, even though it's like not really correct. It's like 75% correct. Okay. So the diagnosis will be based on your leads for a STEMI, right? So know your vessels. So V1 through V4, this is anterior, this is proximal LAD. I heard widowmaker, that's what we used to call this type of MI. Used to have a very, very high mortality rate. V1 through V2, septal, 2, 3 AVF, very, very high yield inferior. They love to go after this. Does anyone know what medication from monobash we typically avoid in inferior MI? Nitroglycerin, right? Because these patients, when you have a right-sided MI, you're preload dependent, right? So you don't want to sever the preload to these patients. They'll become more hypotensive. So your initial treatment really is dual antiplatelet therapy. So that's aspirin with a full dose aspirin and a ADP receptor inhibitors. I don't remember any of those from heme. Clopidogrel, big one. That's Plavix. And then you can consider nitrates for symptomatic relief, obviously not inferior infarcts. And then with the morphine oxygen component, we typically avoid those now unless they're hypotensive or in extreme pain for an MI. And we sometimes start beta blockers during the acute phase of the MI, but what's the main treatment now for MI? Like what's the kind of workhorse of treatment? PCI, right? Percutaneous intervention. DORA balloon time should be 90 minutes. So that's from the time they're in the door to the time they're in the cath lab, should be 90 minutes. So we talked about this now. So what part of the heart do each of these vessels supply? What about the LAD? What does it supply? Give me some, you guys do anatomy. What are some anatomical structures supplied by the LAD?
Left ventricle.
Yeah, LV, interventricular septum, right? Anything else? Any of the papillary muscles? The anterolateral papillary muscle. You got it. What about the PDA? What's like a notable electrical structure that supplies? AV node. AV node. You got it. Then the posterior septum, posterior medial papillary muscle. What's really high yield about the posterior medial papillary muscle? Rupture. It's a rupture, right? Why is it more prone to rupture?
Solely supplied by.
It has a single blood supply by the PCA. Nice work. RCA, what note does this apply?
That's SA.
SA note, nice. And the right marginal artery, what is that supply? Don't overthink, yeah, right ventricle. All right, and then we have your right dominant, left dominant, co-dominant, right? All right, yeah, take a picture if you'd like. If I don't screw up too many of my words this time, I'll just post it on YouTube too, so you can rewatch and take screenshots and stuff.
There. Yeah. 'cause it's-
I was slacking last time, so this time I actually studied for this. I still couldn't answer your question, but I did prepare for this lecture, so I tried. Okay, case number 2. Patient. Oh, this is morbid. The patient from your last story passes within 24 hours of your chest pain, despite your attempts. What's the most likely cause of mortality following MI within the first 24 hours?
Arrest.
You got it. It's arrhythmia. Okay, this is really high yield to know. Examiners love to test this. It's arrhythmia, usually due to some sort of ventricular arrhythmia. Okay, this is just a factoid. High yield to know. Okay. All right, the patient does well. 2 days post MI, he was treated with, he was treated with PCI appropriately following his MI. It's 2 days post MI, and he's now endorsing progressive chest pain that's worse with lying down. He also has a fever, mild shortness of breath. You get an EKG. What do you think is going on here? Yeah. Did you guys go over all the expected complications following MI? I remember there used to be like some anatomy module that we clicked through,
I
and
don't think they do.
it's removed. Yeah.
Don't, yeah.
Okay.
They don't.
So fibrous pericarditis. Actually, ignore this slide.
I mean,
So
we do know, we were taught about this, we just weren't taught about its relation to like post-MI complications.
you're taught about fibrous
But they got
pericarditis,
taught about like papillary.
but not the fact that fibrous pericarditis is related to MI.
Exactly.
That's what I'm hearing. Okay. All right. Well,
Of course it did.
Yeah, right.
Isn't that just constricted pericarditis? That's what we read about.
We had that too.
No, that's.
This is like,
yeah, let's
Diffuse SCL.
we're gonna play a game called I'll go over this really quickly, and then if you don't think it's relevant, ignore it. How's that? Okay. Okay. Pathophys is you get increased neutrophil migration, right? That's the earliest cell that will infiltrate the myocardium and pericardium. And then on EKG, you'll see diffuse ST elevation, PR depression. Management. This slide is not correct. So you do not want to use NSAIDs in fibrous pericarditis, except for aspirin. You can use aspirin and colchicine. Okay. Don't use ibuprofen though, because it can impair wound healing. Actually. All right. So this is very, very high yield, super bread and butter. This is probably, if I can have you walk away with one case you need to know, like down pat for clinical practice and for your exam, this would be it. Okay. And you probably already know what I'm leaning towards here. So let's say a 70-year-old gentleman with a history of hypertension, hyperlipidemia, peripheral vascular disease presented to the ED with shortness of breath. He has had increasing difficulty sleeping, especially on his back. He's slept in the recliner for the past week. On exam, you know crackles in the lungs with 2+ pitting edema bilaterally. You also know JVD on your exam. Vitals are largely within normal limits. That's the acronym you'll learn to use a lot, aside from mild hypoxia and tachypnea. What is your best diagnostic step and next step in treatment?
Echo.
Okay, great. Best diagnostic test is an echocardiogram. What are some serum tests you would also get in this instance? BNP, yeah. So and BNP, not sure how you were taught how to use BNP, but is BNP useful to track over time? Like while they're, is it useful to track as a marker for improvement clinically? General we're taught no, right? So we want to know a baseline BNP, and then if it's significantly elevated, it's indicative of what? Heart failure, right? So we kind of inferred the diagnosis here, but right. Decompensated heart failure. Get used to saying that, knowing about it, treating it, okay? Other things you always want to order are other causes of chest pain and shortness of breath. So that's a chest X-ray, and you'll also see pulmonary edema in case of heart failure, right? But a lot of these patients often have comorbid COPD, so you'll want to look for that as well. And then would get troponins EKG as well. Okay. Also, baseline labs. I don't know if they still ask you in class to list off the labs you would order, but basically CBC, electrolytes, creatinine, they are always fair game. All right, triggers. So the main triggers are the big three, right? Medications or non-adherence, infections, ischemic events, and there's one more massive trigger, very high yield, like after Thanksgiving.
Alcohol.
No, is it-
Yeah, alcohol, but there's a more, prominent one that I'm thinking of.
Salt.
Yeah, it's diet, right? You always ask about what they ate, and it's always ham. It's often ham. It's sodium, right? Helps with water retention. And what happens when you have water retention in heart failure? What causes symptoms in heart failure? 2 words: fluid overload, right? So you're retaining more fluid. You have more fluid overload. Diet plays a huge component as a trigger to heart failure. So what do we use? So if the symptoms are mostly caused by fluid overload, how do we treat decompensated heart failure? Diuretics, right? Diuresis. Squeeze them dry, right? So how do we do that? What is it? Give me some diuretics. What's the most effective diuretics? Hydrochlorothiazide, that's incorrect. That is a effective diuretic for blood pressure control, but not really for acute diuresis.
Aren't these diuretics or is that?
Loop diuretics, very good. What does anyone know what they inhibit? This is you'll learn all about this next unit. So now you have a
chloride channel, I think.
It's the NKCC channel. Yeah, ATP mediated. So
Sodium potassium chloride channel.
yeah, sodium potassium chloride channel. But if they're on home diuretics, you want to give it twice their oral dose, and then you want to know that you want to administer IV if they're acutely decompensated, because if it's oral, a lot of these patients have a lot of gut edema, so you want to consider IV formulation to bypass that. Okay, so Lasix is furosemide. The reason it's called Lasix, does anyone know?
Classic.
It lasts about 6 hours, and then there's Bumix as well. So. All right, does that all make sense? This is very high yield to know. You will be tested on this many times. Okay. Case 10. I don't even think. I think it's like case 3. Patient presents to the clinic after being diagnosed with HFrEF in the hospital last week. He reports feeling much better since discharging on a diuretic and has been able to sleep lying on his back. I'm using this big word for the first time in months. He has some mild pitting edema about around the ankles. Bilaterally, what treatments could offer mortality benefit in HFrEF? This is your other very, very high yield slide. You need to know this.
Beta blocker.
Okay. Beta blockers. Good. What specific beta blockers? There are 2 main ones. Metoprolol. Esmolol is IV, not esmolol.
Okay.
Yeah, it's carvedilol.
I think they taught us 3.
Yeah.
Cardio selective, right? That's all promise.
So your cardio selective, does anyone know the mnemonic for the cardio selective? A-beam. Atenolol, bisoprolol, esmolol, atenolol, metoprolol. But usually the ones we use in practice are metoprolol or carvedilol, okay? Carvedilol is actually not cardio selective, but it still has mortality benefit in heart failure. Okay, what else offers heart mortality benefit? Do diuretics? No mortality benefit in diuretics, but every patient should still be started on them for the symptom benefit. What about digoxin? Mortality benefit of digoxin? No mortality benefit of digoxin. That's correct. Okay, what else has a mortality benefit? Diabetes medication that has mortality benefit. This is newer within the last 5 years.
GLP-1.
Not GLP-1, SGLT2 inhibitor.
Oh yeah.
Okay. What else?
With calcium channel.
Spirulactone. Isn't that-
Calcium channel blocker, no. Spironolactone, yes. In a NYHA, like class 4. So your more severe types of heart failure, spironolactone is a good option. And there's one more that we talked about earlier.
ACE-R. ACE-Rs.
You got it, ACE and ARBs. And how do those work?
Heard inhibit RAS.
Yeah, they inhibit. Well, yeah, they inhibit RAS. They inhibit cardiac remodeling. That's the cause of the mortality benefit. Okay. And then I saw in the chat that you were taught to prefer mineralocorticoid receptor agonists or beta blockers in heart failure to preserve the ejection fraction. Yes, we're on reduced ejection fraction, so always make that distinction in treatment. So there are a lot more medications with mortality benefit that have been studied in HFrEF compared to HFpEF. Okay. There we go. So this is a good slide to take a picture of if you don't know them all. So it's something called GDMT. Have you guys heard that acronym? Goal-directed medical therapy. So this is actually a very important quality metric in heart failure treatment for hospitals. So there's basically always an order set that will pop up whenever you admit or discharge patients with heart failure. And they'll always ask if these patients are on these medications, and if not, why not? Okay. So very, very important to know. Okay.
Do you do one from each category, similar to hypertension?
Yeah. Usually, we patient gets admitted with new onset heart failure. We slowly titrate as many as we can, basically. Yeah, we give them a whole handful of new medications. There is a new one, actually, not new, but maybe not taught as much in class that we really like to use as well. It's an ARB combined with something else.
Sacubitril
Does
valsartan.
anyone know? Yeah, sacubitril valsartan. Does anyone know the brand name? Entresto. Yeah, so that's another really high yield one to know, and it's very commonly used in the hospital. So that's an ARNI. Does anyone know what ARNI stands for? ARNI.
Angiotensin receptor neprilysin inhibitor or something?
You got it. Angiotensin receptor. So that's your ARB. That's your valsartan. Neprilysin inhibitor. Good. Yeah, and that's in the RAS inhibitors part of the checklist, ACE versus ARB versus ARNI. Okay. Any questions about this slide? I'm okay spending more time on this slide in particular because it's so high yield.
You talked more about the last point there, the isosorbide dinitrate and hydrolysis.
Yeah, this is just a board's artifact. Basically, in African American cohorts, there is studies that have seen reduced mortality from nitrate plus hydralazine, but really GDMT is what you want to know about. Okay, but this is sometimes you see this like on board study resources and on board exams. Okay. All right, 18-year-old gentleman presents to the clinic for evaluation prior to starting college athletics. He does not have any symptoms. On exam, you note a crescendo, decrescendo systolic murmur that increases in intensity when supine compared to standing. What's the best next step in evaluation? Good. So next up, echo and EKG, right? And then what is your anticipatory guidance? What's the most likely diagnosis?
Hypertrophic obstructive.
Right. HOCM, hypertrophic obstructive cardiomyopathy. Right. So what do patients with this want to avoid? What should they avoid? Like very strenuous exercise, right? Do you guys learn about this in class?
Yeah, we did.
Okay.
I didn't teach it to us.
Oh,
Can you go
okay.
over why it's
Came up as-
because that I just look for trigger words too much, and I was immediately like,
Yeah, does anyone know why it caused the
But it's
crescendo,
because of the-
decrescendo?
yeah, I said that too. It's
like-
because of that flap, right?
Yeah, when it's like pushing out like the septum. comes
Exactly.
over And it like just creates a smaller outlet similar to.
You got it. So you get this why it's called HOCM, right? Hypertrophic obstructive cardiomyopathy. So as you are contracting, you have that asymmetrically hypertrophic intraventricular septum, right? Which essentially causes like effectively obstruction in your outflow tract. Okay, what else can you see on echocardiogram that's kind of a valvular abnormality with HOCM?
Anterior motion.
You got it. Okay, yeah, Sam. Systolic anterior motion of the mitral valve. There you go. And then you want to look for family history of sudden death because it's what type of inheritance? I believe it's autosomal dominant. Yeah. Okay, management involves beta blockers and sometimes requires pacing, like or defibrillator placement. All right. Okay, do you got this is amyloidosis. I don't know how much you guys really cover this. Mostly amyloidosis is a like type of restrictive disease. So this is kind of anytime you see restrictive, are you thinking more of a systolic or diastolic issue? Right, more of a diastolic, more of a filling issue, right? It's more restrictive, restrictive filling. Okay, so this will be your sarcoid, your amyloid, all your restrictive pathologies. Okay, we already talked about this one. 72-year-old gentleman, EKG with irregular rhythm with no distinct P waves and narrow QRS. What is this?
RVR.
Yeah, you got it. So AFib, this is RVR. This is what we already talked about, just in a kind of summary slide. Okay. Now you have the sawtooth pattern of flutter waves. What did we talk about before?
Atrial.
Yeah, atrial flutter. You got it. Okay. 26-year-old healthy woman feels sudden onset palpitations after drinking coffee, EKG with narrow QRS and absent P waves.
Baby.
Yeah. Some sort of PSVT. Most commonly AV anarchy, right? Let's say, oh, that's chronic. Okay. 70-year-old with COPD. I don't know if you guys cover this. EKG with 3 distinct P wave morphologies. This is multifocal atrial tachycardia associated with COPD. Okay, all you need to know for that one, I don't think you'll be tested on it for this exam, but in the future you will need to know it. So now you've seen it once. Forget about it for now, okay?
Oh yeah, this also.
Okay. 25-year-old gentleman with a short PR interval and a delta wave.
A wolf carpet.
Yeah, Wolf Parkinson's white. Okay. All right, we'll talk about some cardiac meds. Okay. So, what are your calcium channel blockers? Your dihydropyridine ones. What are they used for? Good. Used for hypertension. This is your amlodipine, clofidipine, nicardipine, nifedipine, amlodipine. Okay. Calcium channel blockers. Your non-dihydropyridine. There are 2 of them. And what are they used for? Rapamil and one more. Diltiazem. You got it. Okay. What are they used for?
Rate control.
Rate control. Very nice. Okay. Nitrates. What's their mechanism? How do they work? They vasodilate. You got it. So, well, technically they vasodilate, but they increase nitric oxide in smooth muscle, and they affect veins much more than arteries. They do affect arteries a little bit, so it reduces the preload. Okay. What medication do you want to avoid with nitrates?
Phosphodiesterase.
Yeah, you got it. Phosphodiesterase inhibitors. Like what? Sildenafil,
Why?
which is Viagra. So how do PDE5 inhibitors work?
Increasing what?
They prevent the breakdown of cyclic GMP.
Right, you inhibit the breakdown of like a nitric oxide product, right? So, because how does cyclic GMP work? Cyclic GMP also increases nitric oxide, which is what causes the dilation. So when you have PDE5, you're just getting massive dilation, so you get hypotension. Good deal? Well, not a good deal, but understandable, right? Mechanistically makes sense. Okay. So that's why you don't prescribe Viagra if the patient's on a nitrate, okay? Because a lot of these things you might think they're not as relevant, but if you think about, when you guys learn about ED, it's often associated with peripheral arterial disease, which is often a comorbid factor in heart failure. Actually, ED is considered a coronary artery equivalent for heart failure, for heart attack risk. Okay, so it actually is important to know. Okay, how do statins work? What do they inhibit?
Yeah, so we covered that thing.
So you didn't cover stents. Okay, well that this is very, very important to know. You've all heard of statins, I'm sure. So Lipitor is atorvastatin. HMG CoA's reductase. They should be started in all patients that have MI. So what about cardiac glycosides? Yeah, you got it. Digoxin, how does this work?
Isn't it block?
You got it. It blocks the sodium potassium ATPase, so you get like buildup of the you basically get buildup of the ACTs for easier activation of the action potential, right? So it acts as a contractility agent. Okay, your antiarrhythmics. I am not going to go over all of these. You can learn them. There are a lot of different ways to memorize them. Here are what they are. You have your class 1A, 1B, 1C, right? Remember, you should know whether they affect the atrium, ventricle, or both, right? So your 1A, that's your procainamide and stuff. Your 1B, that's like your lidocaine and maxillatine. 1C is like flecainide, things like that, okay?
Yeah.
Your class 2 beta blockers, class 3, like amiodarone, sotalol, and then class 4 is your calcium channel blockers, right? So the main ones that are annoying to memorize are your class 1A, B, C, okay?
Question.
Yeah, question.
We were like told about sotalol, but I don't think it's like come up in any like question or anything ever. Like
I've only used it like one time. Sotalol. So what does it sound like, right? Sotalol. All the lols are what class? Beta blockers, right? So it's it has class 2 and 3 activity. And amiodarone, what activity does that have?
that's just all of them.
1, 2, and 3.
Oh.
Yeah.
Say that one more time.
Amiodarone has 1, 2, and 3 activity. Sotalol is class 2 and 3 activity.
Yeah, so we're kind of both rate and rhythm.
Yeah, they're both to some extent. Mostly rhythm control though. All right. Fair game for cardiac drugs, right? Like you guys probably spent like 2 weeks on it, and I spent like 10 seconds, so that's as good as I'll get with this. But yeah, just break down everything as simply as you can, because they just come out with so much stuff that you want to break things down into. You want to lump them first and then separate based on that. But think about them in terms of their class and how they're acting, and then you can separate them after that. Okay. So I remember when I used to study the slides, I would just kind of like read every word for the exam, but it's actually helpful to look at the title of the slide too, so you know what grouping to think about them in. But a lot of times I just ignored that. So okay. This is dilated cardiomyopathy can happen with.
Alcohol.
I mean, did you guys cover this?
Yeah.
Oh, okay.
Alcohol is the biggest risk factor.
All right. So patient with heavy alcohol use, there's your risk factor, and prior viral illness that caused myocarditis presents with dyspnea or apnea, leg swelling. Echo reveals enlarged ventricles, reduced EF. So dilated cardiomyopathy. The thing is, a lot of HFrEF also presents with dilated cardiomyopathy. So common causes are like viral myocarditis and can be familial, right? What's the mutation in?
Isn't it
TTN, Titan, like Teen Titans mutation, and it's autosomal what? Dominant, autosomal dominant. Okay. Can also be from some like less high yield things in the United States. So Chagas, hemochromatosis, peripartum, and then stress is your apical ballooning, Takotsubo. Treatment is similar to other forms of heart failure with reduced ejection fraction. Okay, because this is a systolic or diastolic type of heart failure. Systolic, yeah.
Skip ahead to the murmurs. I think we covered everything else.
All right. Then we already did this one.
Yeah,
This
keep going,
hypertrophic
keep going,
cardiomyopathy.
Going.
Infiltrative, we already
Keep
did.
going.
Yo,
Keep
what's
going.
with the splicing,
Keep
man?
going. Keep going. Hey, I wanted to put dialect in there.
Did we already? Oh, we
Yeah, keep
did
going.
these.
There.
All right. You guys can just. I don't. I mean, you guys know these, right? Like kind of más o menos. So you have your cardiac auscultation points, right? So let's just point. I'll point at them and you'll tell me what they are. Okay. So left. What is this? This is my right side. Right upper sternal border. What is this? Aortic. Okay. Left upper sternal border. Pulmonic. Left lower sternal border. Tricuspid. Left lateral inframammary.
Mitral.
Midclavicular. Left midclavicular line. Mitral. What if it's severely displaced and is lateral? Like lateral clavicle line. What would that indicate to you? It's dilation, right?
If you ever get
Or hypertrophy.
if you ever get questions on the wards about what a murmur is, always guess aortic stenosis.
Yeah. So on the wards, if you get questions about what a murmur is and it's in the aortic region, it's likely aortic stenosis. That's because it's very, very common with age. All right? Fair game. After that, it's kind of intuitive, right? So your systolic murmurs will be murmurs that are accentuated in systole. So things that will increase flow through a vessel. So that'll be things like aortic stenosis, right? And then your diastolic murmurs will be things that increase in diastole. So that'll be your tricuspid and mitral stenosis, all right? And then the inverse will be true for the regurgitation, right? So mitral valve, tricuspid valve will be more prominent in systole, and your aortic regurgitation will be more prominent in diastole, right? Easy. All right.